everything speeds up. Everything goes faster, right? Everything's higher, everything's faster. It's crazy, right? Kind of how my brain feels sometimes when I'm sitting up here talking really, really fast to you guys. Think of hyperthyroidism, right? So rapid speech, lack of ability to concentrate. This also has depression symptoms associated with it. These patients have a hard time sleeping. Imagine your brain going 100 miles a minute and your heartbeat is fast and everything's going really, really fast. Hard time sleeping, that's some insomnia. Weight loss, so metabolism is going to speed up for these patients. So these patients will have weight loss. Diarrhea, right? Our GI motility is speeding up here. Patients are always hot. Always hot. This lady has a fan. She's so hot. Her pants are hanging on there by a safety pin because she's losing weight so fast. Okay? They have a lot of them will have what's called exophthalmos. So this is where the eyes, you can kind of see this patient, the eyes are kind of bulging out of their face a little bit. And they may or may not have an enlarged thyroid. They may or may not have a goiter. Remember, that can go either way. Just remember, everything is sped up. Okay? Hyper, think of a hyper kiddo, a hyper puppy dog, I don't know. Super sped up. Everything's really, really fast. You have the zoomies. Okay? And I looked at that. It says breast enlargement. It has something to do with the hormones in the body. We don't have to get the specifics, but I looked at that. I was like, what is that? So it has to do with hormones. Okay, so we're diagnosing hyperthyroidism. The bloodstream's got tons of what? T3, T4 circulating. Okay, so TSH doesn't have to yell when they're being quiet because we don't need that, right? It's got to say, chill out. Okay, so low T3, low T4. So to treat hyperthyroidism, you guys okay? You guys get this? Okay. So to treat hyperthyroidism, we are going to try to block the adverse effects of that excess thyroid hormone, and then also we're trying to suppress the oversecretion that's happening. Okay, so we're blocking the effects and trying to suppress that T3, T4 secretion. Okay, so we can use that using anti-thyroid medications. And I've got another slide that I talk in detail about those. So those are propylthiouracil, or PTU, and methimazole. We can also do radioactive iodine therapy. So this is the preferred method. So we're using iodine. You guys see that word here. And I mentioned when we have too much iodine, it can kill the thyroid, right? We'll have issues there. So the thyroid takes up about 80% of the circulating iodine in the body. So this radioactive iodine therapy, it treats hyperthyroidism by damaging and destroying the thyroid cells through radiation using this iodine. Okay, it's given in a pill form, and this can do such a good job that it actually completely kills the thyroid. Our goal is to put the patient back into a euthyroid state, right? They have hyperthyroidism, all of these T3, T4 circulating. So we're going to give them this radioactive iodine therapy. They do it at home. It's a pill that they take, and it can really throw them the other way and actually kill the thyroid. So then what are we going to have to give these patients? Levothyroxine, right? Synthetic hormones. Okay, so this is the treatment of choice for non-pregnant adults. So this has a delayed response. It may be 3 months before we find out that it did its job, it did what we wanted to do or didn't. So maximum effect may take up to 3 months to see. So before we do this radioactive iodine therapy, these patients will take anti-thyroid drugs, so the propylthiouracil or the methimazole, as well as propranolol for about 3 months before starting this therapy. Because we kind of want everything to be as calm and chill as possible. We do this outpatient, and so these patients are going to have radiation home therapy, or home precautions, sorry. So using a private toilet facility, flushing 2 or 3 times after they use the toilet. We don't want them preparing food for other people for a long period of time. And they also will need to avoid being close to pregnant people and children for about 7 days after the initiation of that therapy. Okay, so don't confuse radioactive iodine therapy with radioactive iodine uptake. Those are two different things, okay? Radioactive iodine therapy, we're treating hyperthyroidism. Radioactive iodine uptake, we're testing thyroid function, okay? So we give them radioactive iodine in that, and then they're gonna use a scanner, and they're gonna measure the amount of iodine that was taken up by the thyroid, and at 2, 4 hours, and 24 hours. And so that'll tell us how the thyroid is functioning. So radioactive iodine uptake test, that's a test, okay? We're just seeing how the functioning is going. Radioactive iodine therapy is treatment, okay? So we could also do a subtotal thyroidectomy, where they can go in, they can remove a lobe or a portion or the entire thyroid. If there's a thyroid there, or if there's a tumor there causing this excess secretion, they can go remove the tumor there. And then once they get that part out, the rest of the thyroid can continue doing its job. Okay, and again, before we do a surgery like that, we're going to be giving medications to block the effects of the thyroid. Because you probably don't want to get put somebody under for surgery if they've got tachycardia and all these other conditions going on. So we're going to try to treat those symptoms before we do a surgery like this. Okay. So these drugs that I just mentioned, the propylthiouracil and the methimazole, these are not curative drugs. Okay, these are not going to cure hyperthyroidism. We're just going to treat this thyrotoxic state. Okay. So these anti-thyroid drugs, they're going to inhibit thyroid hormone synthesis. It might take a couple of weeks after they start this drug before we can see the response. So they may use these for 6 to 15 months in our goal of spontaneous remission. Okay, remember we're trying to get everybody back to a euthyroid state. So we may be giving these anti-thyroid drugs for a little bit to see if we can get them into spontaneous remission. So this only happens in 20 to 40% of patients. So typically we're going to have to do something else in addition to this. So propylthiouracil. So this is the one that can be used for patients that are in the first trimester of their pregnancy, or if they've had adverse reactions to the methimazole. It works quicker. So our goal of getting back to a euthyroid state should happen quicker using propylthiouracil, but the problem with it is they have to take it 3 times a day, right? It's hard to get our patients to do that, to be compliant with their medication, so that's a big hurdle for some people. Methimazole, on the other hand, is only given in a single daily dose. So typically they would use methimazole just because the compliance is there. Okay, so iodine, we can give a really, really large dose of iodine. It's going to decrease the vascularity of that thyroid gland, and that will make surgery safer. And the effects of this happen in 1 to 2 weeks. So because it will reduce its therapeutic effect, long-term iodine therapy is not something that we do. It's not effective in controlling hyperthyroidism. So the way that they give that, they're going to mix that iodine with juice or with water and give it after a meal. And then we're going to have to worry about iodine toxicity. So signs and symptoms of that would be oral swelling, salivation, nausea and vomiting are some things we're going to be looking for if we give a patient iodine. Okay, so these beta adrenergic blockers, these are for symptom relief. Okay, so we can give propranolol or atenolol. So those are just for symptom relief. And again, we're going to give these before we consider doing any other therapies like a surgery therapy, something like that. They're going to be receiving these before that as well. Okay, you guys good on these drugs? Okay. So Graves' disease. So Graves' disease is our autoimmune version of hyperthyroidism. Autoimmune. Okay, star it, underline it, whatever you do. So we have this excessive release of this T3, T4 because of those antibodies that are going to attach to that thyroid, the receptors in the thyroid. Okay. So if this is untreated, it can lead to thyrotoxicosis, or also known as a thyroid storm. Or eventually, like anything else, it can, for lack of a better term, kill the thyroid, and we're going to end up in hypothyroidism eventually. But Graves' disease is the autoimmune hyperthyroidism. So again, all metabolic processes are going to speed up here. Okay. You may see goiters on these patients. You may hear bruits. I can't say this one. Ophthalmopathy. I think I'm saying that wrong. That is that there's an increased fluid in the muscle under and behind the eye. Once that's there, it never goes away. Exophthalmos is when it's actually bulging outward. Okay, the eyes are bulging out of the orbits. Okay, and we may see acropathy on these patients. Okay, so the nursing actions for somebody who has Graves' disease or hyperthyroidism are going to be the same, okay, because they have lots of what? T3, T4, okay? Whether it's autoimmune or it's normal, run-of-the-mill. Hyperthyroidism, lots of T3, T4 being spit out there. So, lots of give the medications for these patients. We want to monitor the respiratory, cardiac status, administer IV fluids as we need it. They need adequate rest. Look at, so these patients, this patient on the lower left, on the before picture, her eyes are closed. But she can't really close her eyes, okay, because of that exophthalmos. So what might we need to do for these patients? Maybe when they're sleeping. They may need to tape their eyes closed. Okay. What are we worried about? Why do we need to tape them closed? They'll dry out. What else could happen? They end up with corneal abrasions. So, and it's really, really uncomfortable for these patients as well. So, taping their eyes closed at night might be something that we might do. Artificial tears for these patients. Elevate the head of the bed. It releases that pressure. So something that can be done, this isn't in any of your texts, but they can do hyaluronic acid filler for Botox preventatively. So if a patient has Graves' disease or hyperthyroidism, they could start doing things like that to prevent this exophthalmos from happening. There's also a surgery. This was developed by a doctor who had Graves' disease, and that's called orbital decompression. So they go in, they actually make the eye socket bigger to ease the pressure on the optic nerve. Because these patients, it's not just like their eyes are dry and they hurt, it actually affects their vision. Okay. There's also a drug called Tepezza. It's an infusion. These patients will have to go into an infusion clinic multiple times. Just FYI for you guys. Okay, so this is more about the radioactive iodine therapy. I think I already spoke on that, yeah. So surgical therapy. So indication. So if their thyroid is compressing on the trachea, we tried this anti-thyroid therapies. We gave it the good, however long, and it didn't respond. We're still in this hyperthyroid state. Or if they have thyroid cancer, then we may move on to this surgical therapy. Okay. So they can remove up to 90% of the gland. We can also remove the entire gland. But if we remove 90% of the gland, it can regenerate, which is pretty cool, I think. But if it doesn't regenerate, what are these patients going to need?
Thyroxine.
Levothyroxine, Synthroid. Okay. And they can also remove some of those nodules are known as hot nodules, that they can go and just remove the nodules that are causing us problems, and they can do that endoscopically. Because you guys know I like these gross pictures, this is pretty cool. So they'll go in and they'll make that incision. So some patients that have this done, they're really worried about their appearance because they're going to walk around looking like they've had their throat slit. So that's a concern for some of these patients that you might look out for. And a lot of times, my mother-in-law, she had, gosh, it's been a long time, probably been 14 years ago, but she had part of her thyroid removed, and they actually put the incision like in a fold of her, like, not a fold, but like in a wrinkle in her neck. And now, like 13 years later, you can hardly tell because it's just kind of melded into that wrinkle in her neck. But for a time, it is concerning. They feel it's kind of embarrassing. It looks weird. It makes them look like they've had their neck slit. But okay, so biggest risk after removing the thyroid is this airway obstruction. Okay, so So look for that. If you're gonna have a patient that has their throat cut open, think about the things that we're gonna be concerned about, the things we're gonna look for. Okay? These patients might have hoarseness that lasts for weeks or months. It could be because they have nerve damage there. And we're gonna talk about hypocalcemia and how that plays into here. But when we go in, we have the parathyroid glands, and they're kind of nuzzled up, and I've got a picture of it. They're kind of nuzzled up to the thyroid, kind of looks like one piece. So when they go in and they do a surgery on the thyroid, they could remove part of the thyroid or all of the thyroid, but they could stun the parathyroid glands, okay? They could stun them where they don't produce, or they could overstimulate them where they produce too much parathyroid hormone. And this is gonna play a role in our calcium, and we'll talk about that, so just kind of let that hang there for a minute. We're gonna worry about hemorrhage, and then we're gonna have these patients seated in a semi-Fowler's position. Obviously, we're monitoring for vital signs, watching for the thyroid storm. What do you guys think a thyroid storm is? I haven't gotten there quite yet. What do you think it is? What does it sound like?
When your body is like everything stops working correctly because of the thyroid.
Because of the thyroid. Anybody else have?
Because of the thyroid removal.
The thyroid's going crazy. It's spitting out T3, T4, and it just causes a crazy storm. And we'll talk about that in a minute. But we're monitoring for that. So what might we see in a patient in a thyroid storm? Cardiac dysrhythmias. All that sweaty, skinny lady picture, like times 100, right? So all of those processes going even faster, right? And here we are. Thyrotoxic crisis is also known as a thyroid storm. Okay, so we've got toxic levels of these thyroid hormones circulating for these patients. So those hyperthyroid symptoms are just magnified and can reach life-threatening levels. Okay, severe tachycardia, heart failure, shock, or hyperthermia. These patients get really hot. Poor body temperature goes up. Respiratory distress. So big deal. If we had a patient that maybe had a surgery on their thyroid, not only can it stun the parathyroid glands, but it could also stun the thyroid itself and cause it to spit out toxic amounts of T3, T4. Okay, so this is a video. This is a great example of a person who's having a thyrotoxic event. I want you to just watch her. I'm hoping the sound works on this. And listen to her and think about what you're observing. Think about hyperthyroidism and what's happening to her, okay?
Sharon, thanks for speaking with us. How long have you felt unwell this time?
4 weeks.
And can you tell us when you were first diagnosed with Graves' disease originally? About?
A year and a half, 2 years ago.
And what's your age now?
42.
And you had a period of treatment and you came under control with medication to start with.
Yeah.
So you went into remission, then you had a relapse, and now you've become unwell again. In the 4 weeks that you've been unwell, what have you noticed?
Stomach cramps, vomiting, and diarrhea. Can't really keep anything down. My ears are blocked. My nose is oversensitive. What with food, the smells of food. And just really lethargic.
With the diarrhea, is it frequent loose motions? Or how would you describe, how many times a day do you normally go to the toilet when you're well?
For bowel movement,
Mm.
I'm lucky to go once a day with bowel movement.
And what about now?
5 or 6 times a day.
Okay. And is it firm or soft or runny?
It's right, well, I'm running.
Okay. With the breathing, you seem to be having some difficulty breathing. What have you noticed with that?
As long as I don't move, I'm okay. But once I get up and walk around or have a conversation, I find it really hard to get my breath.
And have you experienced any palpitations?
But I'm not sure if I sort of know what they are, but I know if I fall down, like to kiss my son goodnight and sit back on down to my heart, I can feel my chest really sort of go boom, boom, boom. So if that's what it is, yes. But
And have you noticed whether that's regular or irregular?
I'm not sure what I'm looking for in that sense.
Well, if you think of a drum beat,
Yep.
where a drum beat is going in a nice regular pattern, even if it's fast, or is it all over the place?
It's all over the place.
We've checked your pulse, and the pattern is called atrial fibrillation, and it's going rather fast at the moment. It's about 160 beats per minute, where the normal pulse rate is between 60 and 100, and it's usually regular. And the last time I saw you when you were well controlled, your pulse rate was 78 beats per minute, and it was quite regular. So things have changed quite a bit. Are you all aware of having lost weight?
Yeah.
What have you noticed?
About 2 weeks ago, I got on the scales at home and I was 68. Last Friday, when I had a blood test, I was 67. And then today is whatever it was today. So
Today was 67, so you haven't really lost that much. Have you been aware of the swelling in your neck?
that's always been like that.
Yes.
So
I wonder, I'll just come from an angle so that we can show the diffuse enlargement of that gland. And we can see that you've got a diffuse swelling in the neck. Your doctor thought it was nodular, but in fact, that's just the shape of your neck and the parts of the gland that are enlarged. But that's called a diffusely enlarged gland. I'm going to just zoom in on that so the students can see it a bit better. And it's quite easy to see that that's enlarged generally throughout the gland. Another interesting thing is that your eyes, you have what's called a thyroid stare, but you don't have thyroid eye disease. So that's good because we don't want the thyroid eye disease. Could you look up at the ceiling, please? Could you look down? Look straight ahead, look to the right, and look to the left, and look straight ahead again. That's fine. Have you noticed any weakness of your arms or legs?
no.
Have you had any difficulty getting up out of a chair?
No.
All right. I'm just going to come up to you and see if we can check your strength in your upper limbs, and then we'll do the same in your legs in a moment. If you could hold your arms out to the side, please. And I'm just going to try and push you down. Hold them up as hard as you can, don't let me push them down. Now you're quite strong because you're very fit, you work out a lot. Okay, Dawn couldn't do that to you. Let's just try with your legs, if you'd like to lie back.
What have you guys observed with her so far? She can't breathe. She looks like she is running 100 miles a minute, but also so exhausted and so fatigued, right? She can hardly catch her. I feel like when I watch this, I have to breathe deeply afterward to remind myself that I can breathe and I can speak slowly and I can be calm. Let's keep watching this. Pay attention. You can see her pulse. You can see that she's in AFib, which is wild to me. And watch, you can even see drips of sweat on her as they kind of get close to her when they're looking at her. Look at her abdomen. Look how quickly she's breathing. You can see
If you
her
just
pulse.
lift this leg up, hold it up there, and don't let me push it down. Alright, now this leg. Don't let me push it down. Okay. Ordinarily, I don't think I could overcome you because you're quite strong. I'll just rearrange the camera and we'll demonstrate your reflexes. Can you see your arm, not me?
Yeah.
You guys see that sweat on her neck? She's glistening.
Okay, thank you very much. I'm just going to zoom in again. And I might ask you just to sit up a little bit higher, please. Turn your head away from this side, if you would.
Feel it sweat. She's beating sweat. You can see her pulse just. Alright, I think that's all it does. Okay. So, when you think of someone who has hyperthyroidism, think of her, but it's not going to be this severe. She is in a thyroid storm, a thyrotoxic crisis. Okay. So for her, all of the things that we talked about when we're treating hyperthyroidism, we're going to do those things, right? We're gonna do symptom care. We're going to try to take care of her fast heartbeat. We're going to try to get her AFib under control. But we're going to be worried about her airway. We're going to be giving IV fluids because we're worried about fluid volume deficits, right? You guys saw her sweating. She looked like she ran a marathon. Have you guys ever talked to somebody who had a really fast heart rate like that? It's really scary. It's scary for them. My sister was having some funky heart stuff going on. She had open heart surgery last year to take care of it, but she has weird electricity in her heart. Anyway, she was in AFib and her heart was beating at 180 something beats per minute for like 2 weeks straight. And to talk to her on the phone was terrifying because she was exhausted. Like that alone exhausted her. She didn't have all this other stuff going on. She didn't have the diarrhea and all the other metabolic processes that are sped up and all of that going on. But it's hard for them. They sound like they can't speak the words they need to speak because they are just so exhausted. Okay, so these patients are going to get those thyroid hormone blockers as well. Treat their hyperthermia, treat the symptoms, oxygen supplementation if they need it. So remember, she's in a thyrotoxic crisis. That is like way far into hyperthyroidism. Yes, ma'am?
I know we said it was like an emergency crisis, but like, is the onset kind of like sudden or?
It can be. It can be. Like if you're having, like the heart rate would probably be pretty above those kind of things. The weight loss might be, because if they had hyperthyroidism before they went into this, they're used to like not being able to keep on weight kind of thing. But yeah, that heartbeat sped up, all those kind of processes, like her being unable to breathe, it might get worse from where she's at. So it may be ramping up because she's not. It doesn't look like she's in an emergency situation at the moment, but she could ramp into that. So does that answer your question?
Yeah.
I think
is there
it's
like a window of treatment for us to have to worry about, or no?
Not that I have seen. Not that I've seen. It's just recognizing those symptoms and the roles that can play on their body system, like being tachycardic for so long. All those things. Yeah. Yes, they can be. Yeah. So all these supportive therapies, we're going to worry about their airway at a certain point, right? We're going to be worrying about that. We're going to be needing continuous cardiac monitoring for this patient. So yeah, and she's in AFib, so they're probably going to be going to treat her pretty quickly, trying to get her into a normal heart rhythm. Giving her those beta blockers, giving IV fluids, all those things we do within the hospital. So yeah, if you were to go visit and think about the state of people. So I have hyperthyroidism. I know that. I go visit my doctor because I'm feeling more tired than normal. I can't quite catch my breath, but a lot of people downplay things like that, and they may show up at their primary care doctor or at the urgent care or something, and they're like, you're in the AFib, we're going to send you on to the hospital kind of thing. It sounds like she was visiting with her endocrinologist, but it's one of those things where it's like people will notice these symptoms and kind of let it go on and linger for days and days, and they may get in a more severe state. We'll have to do more intense therapy to get them back in the right state. Does that make sense? Does that answer your question? Okay. But as far as I know, there's not a window that I've seen that we have to treat them within. Okay, so nutritional therapy. So these patients are going to need 4,000 to 5,000 calories a day. We talked about the metabolism speeding up. So this woman, specifically in a thyrotoxic crisis, needs 4,000 to 5,000 calories a day. So she's burning lots of calories just by sitting there talking to her doctor. Okay, not to mention how many bowel movements did she say? She said 5 to 6 diarrhea bowel movements a day. Okay, so these patients, we really need to worry about nutrition for them. Obviously, we're going to avoid GI stimulants, right? She doesn't need any help with that. GI's being stimulated enough. Increase her carbs. 6 full meals a day, she's probably gonna get really tired trying to get this caloric intake in. So like we've talked about before, slower or smaller high density meals are going to be ideal for these patients, and avoiding caffeine. So these numbers are specifically for patient thyrotoxic crisis, but also if you can imagine someone who has hyperthyroidism, and I'm gonna say run-of-the-mill hyperthyroidism just to separate it for you guys in your brain, they're gonna need a higher calorie intake too, right? Because their metabolism is speed up as well. Not quite as much as these patients, but know that their nutritional needs are going to increase as well. Okay, so this is from your book. This is figure 54.5 on page 1328, but I flipped it. In your book, it's got hypo on the right side and hyper in the left side, and it didn't make sense to my brain. So I just flipped it. So if your brain is like mine, you can refer to this. And if you look at it, you're like, what is different about these? That's it. I just flipped it because it makes sense for the higher to be on the right side to me. I don't know why they did that. I think it's bizarre. But that's for you. Okay. You guys doing okay?
No.
No. Okay. Before we move on, do you have any questions about the thyroid? I know you guys are kind of like, oh, I'm just swimming in it right now. I don't know. Yes.
I still don't understand how iodine would help make T3 and T4, but then you have to use it for people with hyper.
Okay, so iodine. So adequate amounts of iodine. So her question is, she doesn't understand why we intake iodine and we need it for the synthesis, but then also we're going to use it if the patient's in a hyperthyroid state to get them into euthyroid. Is that your question? Okay. So anything in moderation is good, right? So we need iodine for this synthesis to happen. For us to create T3, T4, we need it. But if we have too much, so too much of a good thing isn't always a good thing, right? We have too much of it, it can cause us to burn out our thyroid. And then, so if a patient has hyperthyroidism, we're gonna give them this huge dose of iodine in hopes that we're gonna burn out the thyroid and we're gonna go to, ideally, a euthyroid state, but potentially this patient could go into hypothyroidism, but then we can treat them with synthetic hormones, right? Who is talking? Okay, gosh, I'm like, sorry. I'm like, I've got to ask who's talking because I have no idea. Yes, it is a huge dose of iodine. To put, yeah, so it's like we do that in a medical setting. So we give them this huge dose, we give them a prescription, a huge dose of iodine to kill the thyroid. Could we possibly burn out our thyroid by too much ingesting of iodine? Potentially. Yeah. But that's one of the treatments that we have is this huge dose of iodine. Does that make sense to you guys? Okay. It's just too much of a good thing isn't a good thing anymore, unless you're trying to get back into like a euthyroid state. Okay. Any other questions? You look like, sorry. Do you have a question for me? Okay. Okay, you're just processing.
Yeah.
Okay. I feel like you're mad at me. Don't be mad at me. Okay. Any other questions? Okay. You guys email me your questions. I think this is so interesting. I love this topic. But email me your questions and I can try to explain it in a way that makes more sense. If you need to come take a picture of this, or I can try, I'm probably gonna forget. If somebody wants to, how about this? Somebody email me right now, and I have kind of a version of this that my husband made digital for one time I had a lecture when we had a snow day. If somebody will email me right now, everybody, email me and I will post it on Moodle for you guys, or you guys can take a picture of this to help you process through. But kind of just take it backwards. If it's hyper, we know hyper, lots and lots, T3, T4. So if we have lots and lots of T3, T4, we're not gonna have as much TSH. TSH is gonna be quiet, okay? But if it's hypo, and we don't have enough T3, T4, TSH is gonna be screaming and getting really loud to get the thyroid to make more T3, T4. Okay, and it's that feedback loop. It's constant. Yes.
Where does calcitonin come into play?
So don't worry about calcitonin. I just have it there because it's there. It's a regulating, it's a feedback loop thing that's happening, but it's not important for this topic. Okay? Okay. Are we okay? Okay, please email me, you guys. Seriously, please email me if you. I'm up most hours.